I'm a public health epidemiologist. Spent most of my career both in the public sector. I was the director of preventive medicine for the state of Massachusetts in the Department of Public Health back in the um, uh, late 80s, or excuse me, early 80s. And then I spent the rest of my career pretty much at Tufts University in the School of Medicine, teaching epidemiology and biostatistics. But I'm not an infectious disease doc. And so most of the focus of what I'll talk about today will be the public health aspects of the coronavirus and COVID-19. But I've read the literature pretty extensively and have as good as you can have a handle on currently what's going on. So I'll try to share some of that with you today, but I don't have all of the answers. But hopefully we can get into a discussion, and some of you will have some questions to ask. I'm going to take a break between each section of this talk to see if there are any questions that people want to ask, and we'll do that. That won't be for extensive questions and answers, but if it's an issue of clarification or something that you weren't quite clear about, let's do that. And then at the end, I'll try to leave a bulk of time that we can talk about, have a sort of free flowing discussion of questions that you might have or where things are going. Then the last thing I would say is that Margaret and Susanna have agreed to post all these slides, so you don't have to worry about these slides being available. You'll be able to get them through the library, and they can tell you how that can happen. And I also have a set of resources. There's fabulous resources available on the internet. One of the things that's a major departure from the past is the way information is flowing now, and how rapidly it's flowing and how generally well it's flowing means that you and I here in Shalat can have the same access to data and information that people in all of the major research centers in the country can have. So that's really extraordinary. And we can have it in real time. And that's one of the things that's really made the time that we're in different than others. So I guess the only other things I want to say by way of introduction is we obviously are living in an extraordinary time. As a public health person, I don't think there's ever been a time where we've had a better example of where individual health is inextricably tied to community health. I mean, a lot of the times as public health people, we have to try to convince people about why public health is important and why prevention is important. But if you ever needed a case study of how the factors that influence the community influence the individual, this is it. And this is it in spades. The other thing is that things are changing. I alluded to this earlier at such incredible speed that it's only been 10 months since this virus first came on the scene. 10 months. And in that time, we've sequenced the virus, so we know exactly what it's all about, what its characteristics are, what mutation rates are taking place with the virus. We've developed tests to test for the virus. Some are better than others, and we'll talk about testing a little bit later on. We've developed therapeutics, and just this morning there's an article about Eli Lilly coming up with a new therapeutic for using monoclonal antibodies to treat COVID patients. We've got vaccines in the pipeline, and we'll talk about vaccines later on, and one very promising vaccine. And so it's quite an amazing time. And so what I'd like to do is to start, and this is always the leap of faith, share the screen. And Susanna, you can tell me if this didn't work. So I assume that we're up and running. Susanna, can you see the slide?
Yep, looks good.
Okay.
Perfect.
So Margaret asked me if I would talk a little bit about what the current situation that we're in means in terms of what we can expect this coming winter. I think we're all a little worried about that. We're worried about the holiday seasons that are coming up, how we're going to interact with family and friends. And I think no small number of us are facing that with some fear and trepidation because being inside, not being able to be outside with people at a time when we really haven't seen many of our family and friends in a long, long time is something that worries a great many of us. And it should. And we're going to have to figure out ways to make it through. But the good news is, and I think the bottom line of this presentation is, even though I'm going to seem like a prophet of doom for a while, the bottom line is that I'm fairly optimistic. If we can stay the course and if we can get through the next 8 to 9 months, that things will look a whole lot better by this time next year. So let's dive into it a little bit. And I apologize to those of you who've seen some of this presentation before. It may be a little bit repetitive, but I want to start off by naturally talking a little bit about the epidemiology and what we know about this virus and how it's proceeding through the population. Then talk about what we know about modes of transmission. And this has changed pretty dramatically in the last 3 or 4 months. And it has implications, interesting implications for how we behave with each other and how we behave in the community. Talk briefly about the clinical course and what we know about therapeutics. And there's a lot of good news there. And we need to share that. Testing and prevention and control, of course, are at the heart of controlling this epidemic. And then finally, what does it mean in the coming months? And when we talk about what we can expect in the next 3 or 4 months and how we might want to alter our behavior. So let's dive into the data, and I will try to not prolong this agony too long, but it's really important to have a good understanding of what's currently happening, because we're actually in the beginning of an explosion in cases and hospitalizations, and I'm afraid to say probably soon deaths from this COVID epidemic. Remember that the virus just came on the scene towards the end of last year, 2019. The virus is a corona virus. It came probably out of China. It crossed over from animal species into humans. We're having another crossover we'll talk about maybe later on if we have time, on the mink population in Denmark, which is a worrisome trend in development. And then came to the United States both through China and through Europe. And some of the versions of the virus that came onto the East Coast principally came through Europe. And we could talk about that later on if you want. So on each one of these slides, I'll try to, Susanna, can you see this cursor okay? Then I'm the black cursor?
Yes, I can.
Okay,
Yep.
All right. So I'm going to use this cursor to point out some things on this slide. So this is the number of COVID cases in the United States from March until yesterday. And this is from the New York Times, but similar curves can be found almost anywhere on the internet. And the thing to notice here is on the y-axis, we have cases. So this is 100,000 cases, 50,000 cases. And then this dark red line is the 7-day average, because what it does is it will smooth out this curve, because each one of these pink peaks here is the daily reported new cases. Now, the things to note here are what we call the slope of this curve. And notice that back in April, when the pandemic first broke out, we have this very steep rise in cases. This is called an exponential rise in cases. And this was what we experienced in May. But notice that even at that peak, we were only at about, I say only, but we were at about 40,000 cases a day. There was then a diminution in cases over the summer, and we got a little bit of a valley here. And I actually gave a presentation at the Senior Center right here where my arrow is in early July. And at that time, the case counts were around 46,000. And we were beginning to take off again on another peak. And this came about principally through the opening up of uh, businesses and the opening up of commerce in the southwestern states in the United States. So a lot of this drive in this curve, this next second peak, took place as a result of the spread of the disease out of the East Coast, out of the Northeast. You remember New York and New Jersey and states on the East Coast were experiencing this huge lift here, but that didn't happen until later in the West. And then we had a diminution of cases because they began to put controls and mitigation in place in places like Arizona, and cases began to decline again until we got into school and until we got into the fall. And now, with a loosening up in commerce and a loosening in kids going back to school and kids going to college, and in general, COVID fatigue. COVID fatigue is a real problem. And as somebody pointed out today in something I was reading, COVID fatigue has shifted to COVID annoyance. That people now are just fed up. They're not wearing masks the way they used to. They're not engaged in the kinds of social and physical distancing that they had done in the past. They're just fed up. And what we're seeing is, as a result, a explosion in cases in here in the Northeast, and we'll look at some of that data in a minute, not in the detail that I'm looking at it right here, but in other parts of the country. And the country is on fire. And how we deal with that over the next several months is going to be critical. So I won't spend as much time on each slide as this, but I just wanted to get you oriented. This is a scary time. And the new cases yesterday in the US were at 131,000 right here, and they're going up here. You can see my black arrow, it's going off the screen. That's where we're going to be. We probably will be at 200,000 would be my guess by Christmas if we don't do something. So let's take a look at deaths. Here's a little bit of good news. Mortality means deaths. And here we have on the y-axis, 2,000, 1,000, 0. Notice the huge, we were up over 2,000 deaths back in early April and May. These were principally the early cases of COVID that took their toll on nursing homes and the elder population. And everybody was taken by surprise by this, and it had a devastating impact on people's lives through mortality. Gradually, as time went on, a whole bunch of things began to happen. The incidence of the disease began to shift more to younger populations, to healthier people. So that accounts for some of the decline in deaths because younger people were less likely to die from this disease than older people. Also, hospitals and physicians got better at treating and understanding this disease and how to deal with it. Things like protective equipment and ventilators and other kinds of things that were necessary to manage the disease became available. And actually, deaths dropped to around 400 to 500 per day down as we got into July and August. And there was another peak in August that was congruent with the peak that occurred that I showed you earlier in cases. And then deaths began to stabilize here around under 1,000. But sadly, with this new increase that we're seeing in cases, deaths are beginning to rise again. And deaths are what are called a lagging indicator. It means that as cases begin to erupt, it takes time, obviously, for people to then become sick enough to require hospitalization and then become sick enough to succumb to the infection. And so we won't see deaths take off until probably in the next few weeks it'll happen, and you'll see this curve begin to go up like this. It's quite alarming. We'll be up over 1,000. We're up over 1,000 deaths already, and I think there were 1,300 deaths in the U.S. yesterday, something like that. Okay, so when I gave this talk at the library on October 14th, which was what, a month ago, less than a month ago, this was what the map, the risk map for the U.S. looked like in terms of COVID. The red, this is from something called COVID Act Now, which is one of the resources that I'll share with you later. And they rank risk in state by state, actually county by county. It's one of the really good dashboards that you should look at. And the green, there is no green in this map. There was no green in this map on October 14th, 2020. The green corresponds to, I don't know if you can read it down here, on track to contain the virus. This is this color here, I don't know what you call this, okra or something, is where the disease is growing. And then the red is where there's an imminent outbreak, an active outbreak that's out of control. So this was the map on October 14th. This was the map on a week ago. And if I showed you, I didn't update this slide, but if I showed you for it today, notice Rhode Island now is red. And Vermont was green for most of the summer. Vermont is in serious trouble, as is Maine. Maine yesterday was the #1 fastest growing rate of case growth in America as of yesterday. So the Northeast will not be exempted from this, and it's very possible. New York, Massachusetts has now closed down businesses that will. They've closed down in dining room dining. They're very worried in Massachusetts, and they're of course our neighbor. New Hampshire's had a similar increase in cases. I'll proceed through this more quickly, but these are places with the highest daily reported cases per capita in the US. And these are rates per 100,000 residents. So that means that for the US overall, we're at about 30 cases per 100,000 people. Back in March and April, we were down in the range of like 12 or 10. North Dakota currently has a case rate of 176 per 100,000. South Dakota, 132. You'll recall this was where they had that big motorcycle rally. 250,000 people went into South Dakota. But these two states are also states that have refused until recently to implement any sort of mitigation efforts at all. And there's still no mask requirement in North Dakota. Still no requirement that bars and restaurants be closed in all the counties. And then Iowa and Wisconsin are all central states that are in trouble as well. Now, I guess if there's any good news, Vermont is right about here even now. We're at about 4 to 5 per 100,000 in terms of our rate. So this is 176, this is 4 or 5. You can see where North Dakota and South Dakota are death zones with respect to this virus currently. So, but New England is not exempt, and this is the message I want you to take away. We're in a position where within a couple of weeks we're going to have serious problems on our hand, and my guess is that our governor, who I think, and Mark Levine, who have handled this epidemic so well, are going to be pushed by events to tighten up or close the spigot, I guess is what the way the governor refers to it, more and more and more and more. And I think they've already shut off, as of yesterday, I don't think there's any county in the US that has people that can come to Vermont without first quarantining and without first testing. And that wasn't always true over the summer. Remember, there were like, I think there was a couple of dozen counties in the US that you could come to Vermont to. Not any longer. And I think we're going to have to face the fact that we're going to have to tighten up in the oncoming months. Incident cases in Vermont. I'm almost through the data. We'll get to the fun part in a little bit. But I thought I'd show you this. This is as of what, yesterday. It says 9/10, but it should have said 11/10. I made a mistake. This was yesterday. So these are new COVID cases, rolling 7-day averages. Again, the red line is the 7-day average to smooth out the curve, but the gray peaks are what we're experiencing. This, I think, this very big peak here where we had 30 cases and 35 cases in one day, there was an outbreak at an apple orchard in Shoreham. Then we had the outbreak that took place at the hockey, from the hockey rink in Barrie, and that spread to St. Michael's College. It's now, I think, up to 147 cases as the result of that single event. But more than that, it turns out that a third of these new cases represent small groups of people, small family gatherings or small group of community gatherings of people who have let down their guard, who no longer engage in the same kind of masking and physical distancing that they were in the past. And that's now accounting for about a third of the cases that we're seeing here in Vermont and in the rest of the country. And yesterday, I think there were 43 or 44 new cases here in Vermont. I mean, that's pretty unbelievable. And this curve is going to go up. There's no way to stop that right now. Just two more quick things here. This is from the Washington Post yesterday. These are the states that have had the highest change, or the largest percent change in daily cases in the last 7 days. Notice Maine, 80% increase in the last 7 days in cases. Minnesota, 65, Washington, 58, but Vermont, right here, 47% increase. Now, the numbers are small. I mean, they're small relative to places like North Dakota and South Dakota, but that should be a red flag warning that we have the potential of having a major problem on our hands. This is at a time when the major medical centers in Vermont are experiencing this horrific, the results of this shutdown in their computer systems because of the ransomware that I'm sure you've probably all read about, at a time when we have the potential for a seasonal flu outbreak as well, which would put increasing demands on the medical care system here in Vermont. So it's a worrisome time. This slide is from the Vermont dashboard at the Department of Public Health. This was, again, from yesterday. And this is something that you might want to go and look at every day. If you don't, I try to check it every day. But look at Chittenden County where we are. We've had 134 cases of COVID-19 in the last 14 days. 134 new cases. And we still are very lucky because the number of hospitalized patients is still low. But remember, that's a lagging indicator, and mortality is still incredibly low, the lowest in the nation per capita. And we've had 51 deaths. They hadn't had a death, I think, in many weeks until fairly recently. But this number is going to go up as well. I won't deal with this, but just to point out that racial disparities are a huge issue with respect to COVID-19 nationally and domestically. Maybe not so much in Vermont because of the racial composition of our population, but the disparity between deaths and the ratio of deaths in whites, blacks, and Hispanics is just startling, and is part of the whole dialogue and discussion about race and health care in America. And then finally, this is the last data slide I'm going to show you. These are global case fatality rates. So what a case fatality rate is a percent of people who test positive, who have the disease, who die. So for instance, in Sweden, the case fatality rate of all of the people who've had COVID-19, roughly 5%, 4.8% of them are currently dying in Sweden, whereas in the United States we're at about 2.5%, which is actually quite good relative to other countries in the world. France 2.6%, etc. But this is a tribute actually to how effective we've been able to be in terms of learning how to manage this disease and learning how to deal with people who become quite sick, and to treat them. So there's a little bit of good news there. So I'm going to stop there for just a second and see if anybody has any questions that you want to ask about the data. I'm sorry for spending so much time on that, but I think it's critically important. The takeaway message is that we're in the middle of an explosion of new cases, of new stresses that are going to be put on our healthcare delivery system. But the good news is, and we'll talk about this in the coming slides, that there is a light at the end of the tunnel. And if we can get through this really, really difficult period, I think we're going to get onto the other side and find that we're going to be able to manage this. The other part of the good news is that we now have in place an administration, quite frankly, that is willing to be open and transparent about this epidemic, who've brought science back to the table, who've brought transparency and truth-telling back to the table. And if you look at the people that have been designated as part of the new team that the president-elect is going to bring to the table, I know 3 of those people. They're absolutely outstanding. And the others, just reading about them, suggest that we're going to be in a new era. And I think that they have a chance to hit the ground running and begin to get this thing turned around. So that's the good news. Are there any quick questions before we move on? I guess Susanna, I assume there aren't, so I'll move on.
No, you're welcome to put things in chat if you have a question that
Yep.
Then he can do it at the end, or if you want to unmute yourself and ask a quick question, feel free to do that.
Okay, I'll have a sip of water and we'll go on. So let's talk about modes of transmission. There's some really interesting new developments here, and that actually have implications for our friends at the library. And I think we'll talk about those. So the 4 possible modes of transmission that I want to talk about are droplet and airborne transmission. And this is where the virus, the coronavirus, attaches itself to droplets that we exhale when we sneeze or when we speak, or if we sing or yell or engage in other kinds of vocalization and activities. And there's fairly clear data that droplet airborne transmission is the principal form of transmission of this virus, and we'll talk about that in just a bit. The second category are tactile, what I call tactile and fomite transmission. This is transmission that can take place from the depositing of the virus on surfaces or on objects or on doorknobs or handles or whatever else, and where it's possible to transmit the virus to someone else through that mechanism. And the data are showing increasingly that while that's possible and while it does happen, it's probably far less important than we originally thought. I know many people would do things like decontaminate their groceries when they brought them back from the grocery store, or wipe down handles and surfaces and tables and other such things. And early on in the pandemic, and that was when we thought that tactile and fomite transmission might be much more important than it appears that it is. Now, can it happen? Yes. Is it a major source of infection? probably not, because most of the data has shown that while the virus can live on flat surfaces, can live on handles of cabinets and refrigerators and other such things, that there isn't probably a sufficient amount of virus there to be to easily infect people who might touch those surfaces and then touch their noses or their faces or whatever else. But it's incredibly important to keep surfaces clean anyway for other public health reasons, because you can transmit other viruses and other disease. We're in a seasonal flu period as well, so keeping surfaces dry and clean and wiping them off is continues to be an important public health practice, but it's probably not as important in transmitting the virus. Bodily fluids, we don't know that much about. We do know that you can culture the virus and find the virus in non-respiratory fluids like urine and breast milk and semen, but it's not at all clear that those represent a source of potential infection. And if they do, it's probably minimal at best. And food, the good news is that there's virtually no evidence that food can be, or the sharing of food can be the source of transmission of the virus. But again, you want to engage in good hygienic behavior with respect to how you share foods and how you share utensils and other things. So the message here is droplet and airborne person-to-person transmission is really what we want to be concerned about. So let's just take this little diagram shows a little bit about what we're dealing with. So if you look here, think of this as the width of a human hair, 60 to 120 microns wide. If you use that as a reference point, then these larger droplets that might be associated with a sneeze or might be associated with singing or some other kinds of activity are on this order of magnitude in terms of size. You see this little dot here, hopefully. And then very small microparticles that are sometimes referred to as aerosols are even smaller and are represented by this little dot that I can't even see on the screen, but it's basically right here. The larger particles or droplets, okay, fall to the ground thanks to gravity. And it's felt that the majority of those, which do carry sufficient amount of virus to infect someone, probably fall to the ground within 1 or 2 meters, which would be what, 3 to 6 to 7 feet. But these microparticles, these aerosols, can stay in the air. They float around in the air. If you've ever seen dust floating in the air in front of a sunny window, you have some sense about how these float. And these can actually stay suspended in the air for a long period of time. And it's felt that, but we don't really know unequivocally, that there may be a sufficient amount of virus, RNA virus, in these microparticles to allow someone to be infected. And these distances are much more, and they can go up to 20 feet. Now, clearly, if you're outdoors and there's a wind and there's some sort of air circulation, these particles will be taken with it and hopefully will be carried away from a distance from where you are. But mask wearing is so important because, one, they prevent a lot of the discharge of these particles into the ambient air. And two, and this is something that just got posted last night by the CDC has finally concluded, they've been brought kicking and screaming to this, for political reasons, I should say, not for scientific reasons. They finally issued a guidance that says that masks may also be important in helping to prevent you from inhaling these larger and smaller particles as the result of respiration. So masks now, CDC says, have a dual function. One, preventing the introduction of these particles into the ambient air, and 2, protecting you as a barrier from inhaling them. So you can't underestimate or overstate the importance of masks and distance. I thought I'd show you this slide. This is a slide that shows sort of the same thing, but I thought with respect to a couple of other diseases, Ebola and measles. Ebola was also transmitted through large droplets. And here you see in this diagram, someone who's exhaling, these droplets fall to the ground thanks to gravity. There are other microparticles that are emitted into the air and can travel many, many feet beyond. Measles is probably the best example of a disease that is just highly contagious, much more contagious than the coronavirus. And an infection can take place at large distances away from someone who has measles. And it's thought that each person who's infected with measles could infect as many as 10 other people around them, whereas the infection rates from coronavirus are probably on an order of magnitude below that. So the takeaway message from this is air and droplet transmission are probably the principal source of infection, but that doesn't mean that we should let up in terms of hand hygiene, in terms of not touching our eyes and faces, because at least there is a possibility, although it's probably fairly remote, of transmission in that direction. And I know that here in the Hyde household, we've let up a little bit on taking precautions to wipe down all our groceries. Is it a bad idea to do it? No, it's probably a good idea, but is it going to protect a lot of infection? Probably not. Okay, so let's talk a little bit more about prevention and control. And to do this, I want to just review with you something about the natural history of the coronavirus infection. And for those of you who've seen this before, I apologize, but it's terribly important in terms of understanding control options. So on this slide, we start, this is time along this line, and we start with an exposure. You're exposed to somebody who who's been infected with coronavirus, and the period that it takes place between the time of exposure and the time that you develop clinical signs. This would be things like a cough and fatigue, sore throat, all of the things that are part and parcel of what having an upper respiratory infection might be like. This period is called the incubation period. And so between exposure and onset of clinical signs is the incubation period. Note, however, that in the case of the coronavirus, roughly 40% of the people who are exposed and infected don't develop symptoms. So they don't develop clinical signs of disease. There's no way of knowing they have there's no way of knowing that they have been infected simply by virtue of having clinical signs. The period between exposure and beginning to shed the virus, that means the virus has taken over your respiratory system. It's replicated at a high enough rate that you're actually expelling the virus and transmitting it. That period is called the latent period. And the danger is that as soon as you start shedding the virus, you can infect other people. You can see if you're asymptomatic and infecting other people, they don't know it, you don't know it. That's a huge risk. And if 40% of the population is asymptomatic and shedding virus, you can see how easily the virus can spread. But it also explains why you have to treat everybody as a potential source of infection. You have to use what's called universal precautions. You have to assume everybody you see, everybody you encounter is infected with this virus. And if you assume that, That means you always wear a mask when you see people, when you interact with people. That means you're always careful about hand hygiene. It means everybody is treated as a potential source of infection. And then people continue to be infectious until the disease either resolves because they get better and stop shedding the virus, or they die. So prevention and control involves, these are all things you know this mantra, physical distancing, we've talked about. 6 feet, there's nothing magic about 6 feet. It could be 12 or 15. The safest thing is to make it 100. But 6 feet is felt to be a sort of minimal, provide minimal protection. Masks, we've already talked about, and eye protection are terribly important. I didn't mention eye protection, but the virus can actually infect you through exposure through the eyes. And so if you don't wear glasses, it might make some sense to think about eye protection as well. Hand washing and disinfection. Quarantine is an important part of prevention and control because of the that period of infectivity that we talked about, where people are shedding virus. If you think you've been exposed, then you need to quarantine, because it's conceivable that you've become infected, you're shedding virus, you're either asymptomatic, maybe you'll develop symptoms, but the best way to prevent you from infecting other people is quarantine. That means staying home. That means not interacting with other people. Testing, we'll talk about at some length, but and has been terribly misunderstood and terribly handled in this country, is critically important, because it's one way of finding out who has become infected and who hasn't. Contact tracing is a pivotal part of public health control, because it means that you can get information in the hands of people who've potentially been infected, so that they can take action and engage in behaviors that are going to protect them or prevent them from infecting other people going forward. And so having enough personnel to do contact tracing is critically important. And one of the things that's part of the Biden's new plan is to hire 100,000 people to do contact tracing, which is terribly needed. Vermont currently doesn't have enough contact tracers, although they did for a long time, but the cases are taking off so fast that there's not a sufficient number of people to do contact tracing. Certainly in a place like North Dakota or South Dakota, there's no way they can do it, because the cases are just taking off at such a rapid rate. So I think what Biden's talking about is something like a kind of AmeriCorps, Peace Corps, or something like that, of people who would commit themselves to engaging in this really important public health activity going forward. And then isolation. If people do become sick, they need to be isolated, whether at the hospital or at home, to make sure they don't infect other people. So I'll just stop there for a minute. Are there any questions about modes of transmission or other things, or clarifications before we move on further? I don't know if I can see the chat, but
there's nothing in the chat right now.
Okay.
But
okay.
Feel free. Can you?
Well, we can. Yeah.
I have
ahead.
a quick question.
Yeah.
So if you're outside and you're 6 feet apart, you should still be masked.
Well, I think ideally, yes. And I know it's hard to do. I went for a walk yesterday. Well, certainly, I mean, if you're somebody you share a house with, or somebody that that you live with, your family member or whatever, you can certainly go, I think, maskless, unless you're likely to see other people, in which case, to protect other people and to protect yourself, you probably should wear masks even if you're outdoors. So we went for a walk, my wife and I, to a place yesterday. There were quite a few people, so we wore masks that we were encountering on the pathway and whatever else. Is it a high-risk situation? No, probably not. But it also sends an important message that you care about other people. And it also sends an important message in terms of a covert message that it's normal to wear a mask if you're outside. And so the more we can normalize that behavior, I think the better.
Thank you.
Okay,
It
so
looks like Tom Bates, you need to unmute.
Here we go. One of your previous slides indicated that fomites are apparently not as important as we had thought before in the transmission of the disease. That then speaks to the question of frequent hand washing. How important is that? Or are the recommendations going to change?
Oh, I think hand washing continues to be important for lots of reasons. It's a great behavior to engage in terms of preventing all kinds of diseases, whether gastrointestinal or viral or whatever. And I don't think that is going to change because there's always the possibility of fomite transmission. There's always a possibility of somebody sneezing on the surface, or if they're working at a table like I am here and sneezing, and then having somebody else come along and work on that same surface. This might happen in a place like the library, and then touching their nose or face. So I think it's terribly important. And I think continuing to engage in these cleaning behaviors is important, but because of that, but it's clearly not a major source of transmission that we once thought it was.
Thank you.
Okay. And quarantining books too. I know that's something Margaret and Susanna have been interested in, and we can talk about that more later, but that would represent a fomite as just an inanimate surface or object that can serve as a repository for a potential infection.
So, Jim, there is a question in the chat.
Yep.
It is, Jim, can you talk a little bit about car travel to see family at the holidays? For instance, I assume one must quarantine before travel and probably get tested too, both before and after the trip. Is that correct? And can you talk about the timing of getting tested?
Well, it sounds like, yeah, I'm going to do that right now. The car travel, what was the car travel part?
So it's asking about traveling in the car to see a family at the holidays, but I think there's that part of, I'm sure there's questions about people who have to pick up someone at an airport, and what do you do then?
Yeah, I mean, that's a great question. I don't know of any research that's been done on that issue. I mean, that becomes particularly a problem in the Northeast in the winter, where you can't roll down all the windows. I know that occasionally, a couple of times I've traveled with somebody who in a car, usually I knew the person, but we agreed to roll down all the windows and wear masks. But obviously that's not an option in the winter. And I just think that it's an enclosed space. You don't know anything about, how the heating and ventilation system in the car might recirculate the virus. I think if there's any way possible you can avoid traveling in a car with somebody that you don't know is COVID or is coronavirus free, you shouldn't do it. All right, I'm going to move on. Sorry, my phone keeps going off. Okay, so let's talk a little bit about testing. So there are 3 different kinds of tests that you've probably heard about, and I'm not going to go deep into the weeds on this because it's very complicated. It's very, it's very interesting. It's very topical, but just to give us a little bit of a grounding. So testing is, the process by which you take a sample, and that sample could be of blood, or it could be of a sample from the upper respiratory tract through a swab, a nasal swab, or it could be some other body fluid. And you run a test, and the test is designed to determine whether or not putatively somebody has a disease. And if the test is positive, then the presumption is that they have the disease. If the test is negative, the presumption is they don't. The problem is there are no perfect tests. all tests, regardless of what they are, make mistakes. They make mistakes either in terms of false positives, indicating that somebody has a disease when they don't, or false negatives, failing to find disease when it's there. And the problem is that we operate very often feeling as if a test is the same thing as a diagnosis, and it isn't always true. So, for instance, you can have, whether the test is something like a mammogram, let's say, you can have a mammogram, and it can, when the mammogram is done, it can be, sadly turn out to be a positive, or read as a positive mammogram. But then when you ultimately go and have another test, maybe an ultrasound or maybe a biopsy, it's often determined that in fact that mammogram was read as positive when in fact it wasn't. But and so that also happens with testing for this virus. Now, we usually want to have a gold standard test that is very good at determining whether or not somebody has a disease or not. And that, in the case of the coronavirus, is what's called the PCR, or polymerase chain reaction molecular test, PCR. You'll probably all have heard of it. This is principally the test that's used now in Vermont. I think Vermont Department of Health no longer, or doesn't yet, recommend using any of these other kinds of tests. But the PCR tests for the actual virus itself, the presence of the virus itself, and it does it with taking a nasal or throat swab through having it stuck up your nose. Some of you probably had this. It actually looks for evidence of the virus directly itself. And it's put into a little machine, or it's not put into a little machine, but some of them are sent off to a laboratory, some are put into a machine. The amount of virus is amplified, and then it's determined whether or not there is evidence of the virus. It is not quick. I don't know, this is a mistake. It shouldn't say less than 20 minutes. The PCR tests take a long time to be done. Usually it's many minutes and can take hours for them to be done. So it's not really a quick test. It's got very limited accuracy early on in the infection, and I'll explain that in a little bit. But probably shouldn't be done any less than 4 days after you think you may have been infected. And I'll talk about that in just a minute. But the interpretation is clear that if you have a positive PCR test, you clearly are infected with the virus. Whether or not that confers long-term immunity or not, nobody really knows. The second type of test is an antibody test that you've probably heard about, and this is done through a blood sample as opposed to a sample from the respiratory tract. There are lots of different types of antibody tests, and this looks for antibodies that are in response to infection with the virus. And these have highly variable accuracy in terms of their false positive and false negative rates. But antibody tests are only really effective after you've been infected, after you've begun to shed virus over a period of time, and they might continue to stay positive well after a PCR test would be negative, for reasons that I'll show you in just a second. And what they mean is that they mean that at some point in the past you were possibly infected with the coronavirus, and whether or not that means you have long-term immunity, nobody really knows. So the antibody test simply shows whether you were likely infected in the past, not whether you're currently infected. The antigen test has had a rocky history recently, but has a lot of potential because it can be done. It's looking for proteins that are associated with the virus, but not the virus itself and not antibodies. So the antigen test is usually done with a nasal or throat swab. It can be done real quick, sort of like a strep test can be done in a physician's office. Um, it's got these antigen tests that have been developed. There are lots of different ones of them. You may have heard about the antigen test that was used down in Manchester, Vermont, and produced a lot of false positives that caused a big to-do earlier in the summer. But it has the potential of being a game changer if the false positives and false negative rates can be worked on, because it's inexpensive. It can be done at the point of care in a physician's office, and it can indicate whether or not you've been infected. These antigen tests are only very, very few of them have been authorized for use by the FDA. And in Vermont, they may be used, but I don't think the health department certainly doesn't recommend their use. Now, let me explain a little bit of what I talked about earlier with respect to these tests. So, and this diagram is a little complex, so I'm gonna spend just a couple of minutes on it. So along this axis here on the bottom, we have time again. So if we start here, it says there's a 0 here. I think you notice, and here it says -2, and here it says -5. And these are days. So if we start at time 0, assume somebody is infected here at this point. It takes a while, if you become infected, for a sufficient amount of virus to be replicated and to show up in your upper, excuse me. Aren't you glad you're not actually 2 feet in front of me instead of separated by a screen? Anyway, it takes a while for a sufficient amount of virus to be developed so that a PCR test, a nucleic acid test, can actually detect it. So it's thought that between 4 and 5 days after infection, there's a sufficient amount of virus to show up as a positive PCR test. And again, this rather repulsive diagram simply shows how you have to have this long probe go into the back of the throat or to up into the sinus cavity to get a sufficient amount of virus to do the PCR test. Then, as the amount of virus over time begins to increase, let's say this is 2 to 5 days after it peaks, then if you take a PCR test, it's going to come out positive almost every time. And the PCR test is really, really good at detecting disease if it's really there. Notice down here, these are antibodies, the red line. So your body immune system responds to infection by the virus and begins to develop antibody, but that doesn't take place till about 4 to 5 days after you begin to develop symptoms. So if you took an antibody test in here, it's very likely going to be negative. It will show no history of infection. And it's not until probably 10 to 12 to 14 days after symptoms begin that an antibody test will be positive. So you can see how antibody testing doesn't do very much in terms of telling you about active infection. But the other thing to notice is that over time, the PCR, the amount of virus that you're expelling because you're either recovering or you're getting better, drops. And so the chances of a PCR test being positive down here is very small. So when you test is critically important, and interpreting a test result is very, very important in terms of when exposure potentially take place with respect to symptom development. So there's a lot going on here, but it's worth considering as you think about testing. Antigen tests, if they became effective, might well be effective in this range here. And so antigen tests could be terribly important and could be a game changer. And one of the things I think that this current new administration has to do is to do an Operation Warp Speed with respect to testing, which for whatever reason, the previous administration decided wasn't all that important. So let's talk a little bit about therapeutics. And again, I'm not a clinician, but I want to just share a little bit of good news here with respect to what the data show about coronavirus. So this case flow diagram is really designed to simply show you something about what we expect within to take place over time with respect to somebody who's infected and tests positive in terms of what the clinical outcome might be for them. And so here's the way to read this diagram. It looks complicated. It isn't all that complicated. So again, we have time on the bottom. And let's assume that we have 100 people, n equals 100, who test positive, who truly have coronavirus, have been infected with coronavirus. 40 of those 100, 40%, are going to end up as asymptomatic. They're not going to have symptoms. They're not going to know they're sick. But remember, importantly, they can be shedding the virus. And therefore, they're sources of infection and sources of propagating the infection more extensively in the population. But over time, they clear the virus. They don't any longer become infected. And so they recover. Whether they have long-term immunity or not, we don't know, but they don't end up getting hospitalized. They don't end up eating up resources of the healthcare system. 60 of those 100, however, are going to have some kinds of symptoms. They could be very mild, they could be severe, and it depends on what other risk factors might be associated with their disease. If you're obese, if you have a history of diabetes, if you're older, 65 or older, and have other chronic, what we call comorbidities, then you're at high risk. And even if you have mild symptoms, you really need to be followed up very, very carefully. But of those 60 who have some form of symptoms, roughly 48 of them are going to be treated at home. They're going to be treated by, by treating their symptoms, by staying at home, by isolating themselves, by letting their body's immune system take over and let them recover. 47 of those 48 people are going to recover and not require anything more than just sort of symptom treatment. Maybe one of them is going to end up in the hospital or is going to die, but it's statistically very low. Of the 60, 12 may end up in the hospital, and of those, maybe a couple of people will die, but 8 or so will recover. And we're getting much better at this, so the recovery numbers are getting better. So that's a hypothetical case flow for 100 people who might be infected with the coronavirus. Now, the sort of treatments that people get are really treating symptoms. I've alluded to that already, providing just supportive care, getting rest, getting fluids, these sorts of things. And for the bulk of people, that's going to take place in the home environment. It's not going to be burden on the healthcare delivery system. There are people who get in serious trouble who require hospitalization and then require these therapeutics. And these therapeutics that are highlighted here, remdesivir, which is an antiviral, which is designed to cut down on actually the virus load and viral activity. Regeneron, which is an antibody cocktail that is provided to patients to try to get the immune system up and running quickly to combat the virus. And yesterday, Eli Lilly reported on a new antibody cocktail. I can't remember if they've given it a trade brand name or not, which is one of these antibody cocktails like Regeneron, and dexamethasone, which is an anti-inflammatory because steroid, is another treatment that is used to try to keep the immune system from going into a hyperdrive and causing other kinds of organ damage to the cardiovascular system, to kidneys, etc. Now, I highlighted these because these are the ones that President Trump got when he was treated at Walter Reed. And this combination of drugs is not available to everybody and is not used everywhere, but they're beginning to be part of customary practice in severely ill COVID patients in hospitals around the country. Convalescent plasma is something you may have read about or heard about. There's not a lot of good data suggesting that people who've recovered from and whose plasma then has been extracted and reintroduced into people who are sick has been effective. And then, of course, hydroxychloroquine, which was the thing that that the Trump administration was pushing for months and months and months, has been proven to be absolutely useless. And it was a total waste of time. And it's a disgrace that we allowed ourselves to be dragged through that. There's just no other way to say it. So clinical consequences of this disease have important public health implications because they're long-term, some of them. There are people like long haulers, people who have been, we've now been only at this 10 or 11 months, but there are some people who were infected and recovered back in April and May who are still having symptoms, neurologic symptoms, neurologic effects from COVID. It is not a walk in the park. And things like fatigue, mental stress, headache. There are some people who argue that the COVID-19 is more than a respiratory disease. It is a cardiovascular disease because a very high percentage of people, or not insignificant, let me put it differently, a very not insignificant percentage of people who are infected develop severe cardiovascular complications. And there have been studies actually of college athletes and professional athletes who've become infected either through, because they are engaged in sports. And most of these have been football players. And some of them have developed cardiomyopathies that are very serious and very severe. And Alex Rodriguez, who was a pitcher for the Red Sox, my favorite Red Sox, came down with COVID and is currently, it may be career-ending for him in terms of long-term effects. So getting this disease is not a walk in the park. And just yesterday or 2 days ago, there's been a study published on pregnant women. And so for young people who think that getting coronavirus or COVID isn't any big deal, let me point out that if you're of reproductive age and if you're planning to have a baby and if you're pregnant, you want to be really, really careful because the data on things like prematurity and data on things like clinical course of disease when in treatment, if you become infected, suggests that pregnant women are at risk of serious complications, not only to themselves, but potentially to their babies. So this is a message that needs to get out to young people who of reproductive age under 40, who aren't for other reasons particularly worried about coronavirus. So that gets us to vaccine development and the end of what I wanted to talk about. And I think I'll just plow into that and then we'll have time for questions. So amidst all this doom and gloom, there's a good story. And one of the things I think that the administration has done well is their response in terms of vaccine development. And there are currently over 170 vaccines in some form of development in the pipeline somewhere. They're either in what's called phase 1 or phase 2 or phase 3 trials. But most likely, you've all heard about let me go. Most likely you've all heard about this most recent Pfizer BioNTech vaccine. And this was developed, BioNTech actually is a German company. It is headed by a couple of Turkish German scientists. I just read their profile yesterday, a fascinating couple of molecular biologists, and they are the ones who've actually developed this vaccine and this approach to developing RNA vaccines. And then they partnered with Pfizer because Pfizer has the expertise in terms of scaling up vaccine production and vaccine development to develop this vaccine that you may have heard about. It's interesting that Pfizer was not part of Operation Warp Speed. Mike Pence tried to take credit for this, but in fact, Pfizer and BioNTech took no money for the development of this vaccine, although the government has decided to, or has contracted to purchase, I think, 300 million doses of it. So the vaccine has some issues associated with it. And before people get too excited, we should point out that there are only, I think, 94 cases that have been of COVID infection that have been reported in the early data on this trial. But none of these data have been reported in the scientific literature. It's only in the press, and that's very odd. And of course, most scientists are waiting to see the data come out in the literature, but it certainly appears to be very, very promising. What we don't know is because of the 30,000 people that were part of this vaccine trial, only 94 of them have ended up, 4 in the placebo group and 90 in the treated group with COVID. We don't know anything about the long-term immune status of this population. Will they continue to be immune to the disease for a year, for months, for weeks, for 2 years, for forever? We don't really know. We don't know anything about that, and can't know until the vaccine gets out and deployed and we can follow those populations over time. We know nothing about whether or not the vaccine is effective with older people, with younger people, with children. I don't know if any children were part of that trial or not. I haven't been able to find that out yet. We don't know about whether or not the vaccine is effective across racial groups. We don't know if the vaccine is effective across groups with different kinds of comorbid conditions. So there's a lot we don't know. But the good news is that I think that we can count on our federal officials at the FDA and elsewhere now being much more open, much more transparent, and much more much more transparent with data and information about this trial. And then finally, we don't know about what the acceptance rate of this vaccine will be. Polls show, and maybe polls aren't to be trusted anymore given what happened a week ago, but polls show that as many as 40% of the population are reluctant or vaccine hesitant to take this vaccine. And that's very worrisome and very sad, because if the vaccine is as effective as we think it might be, maybe around 90%, which would be unbelievable. The FDA was looking for 60% as a success rate. But anyway, if 40% of the population won't take it, then the protection that vaccine affords is reduced remarkably. We really need to have people take that vaccine. Tony Fauci suggested that this vaccine may be available to the general public by as early as late April. I think he's overly optimistic about that because there are huge logistic issues involved with this particular vaccine. And those are things like what's called the cold chain. The vaccine has to be kept at around minus 90 degrees Fahrenheit in order to be stable. And there are very, very few, except in tertiary medical care settings and in biotech companies, places that have sufficient freezer refrigeration space to keep things at that low a temperature and to maintain that low temperature. The vaccine is distributed in batches of 5,000. So if you want to distribute it to nursing homes or to a small hospital where they may only need a few hundred doses, that's going to be a problem. And keeping it at that level of refrigeration for long enough so that it doesn't go bad. The vaccine requires 2 shots, not 1. And those 2 shots have to be separated by between 3 and 4 weeks. So in order to be effective. So it's one thing to get people to go and have 1 shot, but it's another thing entirely to get them to go and have 2. So there are lots of daunting things that have to be dealt with respect to that particular vaccine. So I'm going to skip ahead to, let's see, hang on one second. Let me just say that there are at least 53 vaccines that are currently in development. And there's a really terrific website you can go to. It's right here in the sources at McGill University called the Vaccine Tracker. And it provides terrific information right up to the date about these different vaccines that are in development, where they are in development, where they are in production, where they are in terms of certification, and what the trials have looked like. So I would encourage you to do that if you're interested in the vaccine issue. But so there's a lot of hope. And even if this Pfizer vaccine turns out to be not as quite as effective as they once thought, there are other vaccines from Moderna, from AstraZeneca, and other companies that are in development that are right back in the pipeline. And so that's very encouraging. There are lots of challenges, and I've talked about all of those challenges in terms of manufacturing and distribution. I think that we can't count on the vaccine to really be available and to be widely disseminated much before the 3rd quarter of 2021, about where we are now. But I think it's a real light at the end of that tunnel. In the interim, we're going to have to keep using PPE, keep doing universal precautions, keep people engaged in the sorts of activities that we've been engaged in up until now, but even more so to get through the sort of dark days that are ahead. And to remember that vaccines are not going to be a silver bullet necessarily overnight. It may be that we have in store for us, humanity does, future coronavirus type pandemics. And what we're going to have to learn from this experience is that we're going to have to beef up our public health infrastructure and be prepared to deal with them. But right now, I think that's extremely promising. And this slide simply shows it's it's just a page out of that McGill website that I mentioned. So tips for winter living in COVID-19, and then I'll be done. Get a seasonal flu shot. I haven't mentioned this, but if you haven't gotten a seasonal flu shot, be sure to do it, because one of the things we don't want to do is burden the healthcare delivery system with another respiratory disease at the same time that we're trying to deal with COVID. So get that. I think it's really important to be aware of the level of risk that's in your own environment. And as you can see, Chittenden County is not alone. We're not isolated. And you better internalize that and take that to heart. Be really wary of upcoming Thanksgiving and Christmas. I know that it's very, very hard. In our family, we're not going to be able to get together with our kids and our grandchildren. But I think it would be very wise not to do that if you can possibly avoid it. Keep your number of close contacts small, and you might want to consider a pod or some sort of quarantine. There's a huge literature on that, and it's potentially risky. Nothing is without risk, but it's worth considering it. Spend as little time indoor in confined spaces in high-risk activities as possible. If you go to a grocery store or you go to a store where there are lots of people, even though they're engaging in best practices. Spend as little time in there as you can. Know what you want to buy. It's no time to do, to do window shopping. It's no time to sort of cruise around and do impulse buying. Know what you want, get in and get out. And remember to practice universal precautions that assume everybody's infected and everybody's going to infect you. And then finally, keep a log or diary. This is something I do every day. I write down where I went and if I saw anybody or did I go to the post office or whatever. It's just 1 or 2 lines in a book with a date so that if I were to get sick, I would be able to help a contact tracer, or I would be able to know who to call, that to call a place or to call somebody and say, I think I may have, I was there, and you may want to alert people there that are that may have been there at the same time. It's only good public health practice, and it's only good community practice. So with that, I'm going to stop. I'm just taking a look at my notes, and I think what I want to leave you with is I'm actually optimistic. I think that if we can get through the next 8 or 9 months, I feel really good about the plans that are in place by the current administration, and the fact that transparency, truth-telling, and science are going to drive policy. So I will stop there. I went a little longer than I wanted to, Susanna. I apologize.
Oh, that's right. It's very informative. Thank you so much. There are a few questions in the chat,
Yep.
which either can you see them or would you like me to read them?
Let's see, chat.
So
yes, hang on 1 second.
Okay.
Okay, so one, Jim, can you talk a little bit about car travel? I think that's the
Yeah,
one
we
I
answered
did.
that one. Yeah.
What about protocols, behavior for someone who has recovered from a confirmed case of COVID? So if you've recovered, and I assume by recovered, you mean your symptoms have disappeared, you'd certainly want to be tested, I think, to make sure that, and you might want to take an antibody test to see whether or not you have antibodies. And you might want to consider yourself still infectious, unless you recovered a month ago. I mean, I think there's very little evidence that people continue to shed virus after more than about 3 weeks. I don't know that for sure, and I'm not a clinician, but those are the things that I would do on that one. I would just assume that you're still potentially infectious even if your symptoms have cleared up for at least a week or 2 weeks ago. And then how long do the antibodies last in the body? We don't know the answer to that question. That's a fabulous question, and we wish we knew. We don't know whether antibodies continue more than a few months. There's some evidence that they actually decline after a short period of time, but whether they decline so much that you're no longer immune or you are, we just don't know.
And then you'll see that someone asked you to touch upon kids going back to school, play dates, carpooling.
Let's see. Another question from someone who's, could you touch upon kids going back to school? Okay, play dates, carpooling. Sorry, though, print is very small. I can't. It's a problem with having bifocals. I think a lot of, and this I know not a whole much about because I don't have kids of school age. So maybe, Susanna, there are other people that could answer this question better than I that are online. But I think what a lot of families have done is this kind of podding or quarantines. They've set up these small groups of people that they've agreed that they will share play dates with and share carpooling with.
Mm-hmm.
It becomes more complex when is it the grandparent who goes to pick up the kids instead of somebody who's part of that quad, or is it a neighbor who goes to pick, those are things that you'd want to really be careful about. There are no easy answers because having a family and having kids aren't congruent with easy answers. So I don't have a lot of wisdom to share about that, except just be very, very careful. Keep your number of close contacts as small as possible, and always and always engage in those preventive behaviors if you can. Jim, my family plans to quarantine and get tested before our Christmas, but what about the timing for getting tested? How many days before, etc.? So look at that diagram that I showed you earlier about the about the virus and when symptoms begin. I would say that you want to test, within a couple of days, if possible, of getting together. Probably maybe 3 or 4 days would be ideal. If you test negative, and I would get a PCR test. I'd forget an antigen test. Do not accept an antigen test. Make sure it's a PCR test. If it's here in Vermont, chances are that's what it's going to be. But if you look at that diagram, that means that if you're actively infected, even if you're asymptomatic, you're very likely to pick it up at that period of time. But equally important is quarantining before, just making sure that before you get together, you really make sure that the family members that are coming from distant places have been careful about quarantining.
And David, did you have a question? You'll need to unmute first.
There's been recent research about humidity and in Princeton, humidity and ventilation. Have you any recommendations on that, especially in the winter in Vermont? In our houses are quite dry and not vented.
Yeah, it's a great question. I've just started reading about that. So it turns out that low humidities and cool temperatures are ideal situations for these coronaviruses to thrive and be transmitted, even more so than warm and humid conditions. So, for instance, and ironically, some of the information that I just read a study out of Brazil about this, where they were really interested in looking at whether or not the risks were reduced in warm tropical climates versus the kind of climate that we live in. And it appears to be that, that it's a kind of perfect storm for us here in the Northeast. We're going into a period when we're going to have cool, dry conditions, which are ideal for the transmission of these particular viruses. So it makes us want to be even more careful. But any more than that, I really don't know, David. I just haven't read a sufficient amount to know about it. But it's well worth doing some research on it.
I mean, many years ago, growing up, parents had vaporizers or when the kids had colds and things.
Yep. Yeah. Well, we do this in our house. We have humidifier that we run in our house because it gets so dry, and also because we have hot air heat. Then that exacerbates the problem. But I think we should consider that we live in kind of a perfect conditions for the transmission of these kinds of viruses and be doubly careful because of that.
Margaret, it looks like you're unmuted. Did you?
I did. This is a library specific question though, so I don't want to take time from anyone else who might have a question.
Go ahead.
Quarantining those books.
So currently the library policy is what, 5 days, am I right, or 3?
Yep.
5
days.
Yeah. So I guess, Margaret, from what I read, and I've been reading up a little bit on this, I think you could dial that back.
Okay.
I'd go back to 3 days.
Okay.
And I think it would be more than sufficient. And so I think that'll mean there'll be a little bit more rapid turnover that you'll be able to engage in. Because even the data, I don't know if you remember, but the data, when we looked at the data on 5 days, you can still culture the virus after 5 days on a page of a book or on a cover of a book. But it's at such a low level that there's really very little evidence that it would be even close to a sufficient enough to infect anybody. So, and in fact, in that study, as I recall, when we looked at it, the levels of viral load were so low that it was below the detection level of the laboratory measurement devices that they were using. So I think going back to 3 days would be more than sufficient.
And we are sanitizing books before they go with the covers of books.
Yeah, but I would certainly continue to do surfaces, like tables and doorknobs and, all of those things. There's no reason to stop doing that. And I think if nothing else, it will prevent the transmission of seasonal flu and other colds and other
A lot
things.
of other stuff out
Yeah,
there.
yeah, it's a good behavior to engage in. And
All right, thank you.
Thank you.
so I guess we're done.
Unless anyone else has a quick question, I think.
Yeah, you
Great.
gave
Thank
us
you
a lot
so much.
of- Yeah, thank you very much.
So I just would end by saying that Margaret has the slides if you want them. And then there's a companion document, which I think is a PDF. Did I give that to you as a PDF as well?
Yeah.
And that's a list of really great resources that are available on the internet on all of these topics, from vaccines to potting and setting up quarantine teams to the latest data on from the CDC and other places. I mean, we're blessed with having really fabulous resources of data and information that available to the average person that just it's never existed before, and that's it's a huge bonus. So thank you all.